Hey there, welcome to my channel. This lecture will focus on the pharmacology of medications used to treat heart failure. The simplest definition of heart failure is a progressive, chronic condition in which the heart muscle cannot pump enough blood to meet the needs of the body. A fundamental physiological principle, known as the Frank-Starling Law of the heart, explains how the heart pumps out as much blood as it receives, allowing the blood to move through the body in a regulated manner. This law specifically indicates that as the ventricle fills more fully, the contraction force increases and the cardiac output increases as a result. To pump blood throughout the body, the ventricles, which are the lower chambers, and the atria, which are the top chambers, contract and relax in turn in a normal heart. There are now four main processes that blood takes through the heart and lungs. Heart failure occurs when the ventricle becomes sufficiently full of blood that the heart's ability to contract becomes less effective. Heart failure can now show up as either diastolic dysfunction or systolic dysfunction, depending on the underlying etiology. The heart's ability to pump blood is compromised in systolic heart failure due to weakening cardiac muscle. We call this decrease in blood pumped out of the ventricle, known as the ejection fraction, the result of poor ventricular contractility. Systolic dysfunction-related heart failure is usually linked with an ejection fraction of less than 40%, even though the normal range might be between 50 and 75%. This is the reason heart failure with reduced ejection fraction is the most prevalent term used to describe systolic heart failure. In contrast, the heart contracts normally in diastolic heart failure, but stiffens and is unable to relax sufficiently to allow normal ventricular filling. Therefore, while having a reduced volume of stroke and cardiac output, people with diastolic heart failure have an ejection fraction that is comparatively normal. This is why heart failure with preserved ejection fraction is the most common term used to describe diastolic failure. Well, when heart failure occurs, the body will attempt to adjust through two highly regulated systems in order to counteract the impact of decreasing cardiac output and consequently decreased perfusion to vital organs. The first one is the increase in activity of the sympathetic nervous system. The aortic arch and carotid sinus arterial baroreceptors sense blood pressure variations in response to a decreased cardiac output. These changes trigger the release of norepinephrine, which in turn activates the beta-1 receptors in the myocardium, SA node, and ventricular conduction system. Increased cardiac contractility and heart rate due to stimulation of these receptors result in higher stroke volumes. The second main compensating mechanism is the renin-angiotensin aldosterone system. Renin once in the bloodstream, it reacts with angiotensinogen, a circulating substrate mainly sourced from the liver, to generate angiotensin I. Once angiotensin I passes through the pulmonary circulation, it is converted into angiotensin II by an additional enzyme known as angiotensin-converting enzyme, which is found in abundance in the lungs. Vasoconstriction resulting from activation of angiotensin second receptor type 1 in the endothelium of systemic arterioles. Moreover, angiotensin II acts on the angiotensin receptors in the adrenal cortex to trigger the release of the steroid hormone aldosterone. Aldosterone then binds to the nuclear mineralocorticoid receptor within the distal tubule and collecting duct cells, where it increases the expression of genes encoding the sodium-potassium pump and epithelial sodium channels, thereby promoting potassium secretion and sodium and water reabsorption, which increased plasma volume and blood pressure. Moreover, venous and capillary hydrostatic pressures are increased by vasoconstriction and fluid retention, which forces more fluid from the blood into the tissue and causes edema, especially in the legs and feet. Increased blood volume and peripheral resistance put additional strain on the heart and accelerate the myocardium's worsening process, which results in structural cardiac remodeling. By activating cardioprotective natriuretic peptides at this time, the body is trying to compensate overstimulation of the sympathetic nervous system and the renin-angiotensin aldosterone system in an attempt to maintain circulatory system homeostasis. However, this response alone cannot stop the heart failure. Both ivabradine and beta blockers mainly lower the heart rate and contractility. Hydralazine and isosorbide dinitrate both have vasodilator effects on the smooth muscle of the arteries. Angiotensin receptor neprilysin inhibitors block the neprilysin enzyme, which inhibits it from breaking down natriuretic peptides. Also, the ACE inhibitors act to block angiotensin II. Patients with heart failure now require a complicated pharmacological regimen that may include many medication types. Let us now discuss each of these individually, beginning with beta blockers. In order to reduce heart rate and contractility, which in turn lowers cardiac output and blood pressure, beta blockers bind to beta-1 receptors in the heart and inhibit the activity of norepinephrine. Note that a lower heart rate allows longer diastolic filling time, which usually results in an unchanged stroke volume. Similarly, by inhibiting the B1 receptors in the renal juxtaglomerular complex, certain beta blockers additionally decrease the release of renin, which may decrease the severity of both the volume expansion and angiotensin II-induced vasoconstriction. It's important to keep in mind, though, that this is not the main way that beta blockers work. Just 3 beta blockers, metoprolol, bisoprolol, and carvedilol, of the several available on the market, have been shown to lower mortality in individuals with heart failure. Of these 3, carvedilol has the special pharmacological ability to inhibit alpha-1 receptors on the smooth muscles of arteries and veins in addition to beta-1 receptors in the heart. Carvedilol lowers total peripheral resistance by causing arteries to dilate and inhibiting norepinephrine from activating the alpha-1 receptor. All right, let's move on to the angiotensin-converting enzyme, ACE inhibitors, which are the next class of medications for heart failure. This class of drugs selectively inhibits the angiotensin-converting enzyme, reducing the generation of angiotensin II and its effects on vasoconstriction, aldosterone secretion, and ADH. Furthermore, ACE inhibition increases levels of bradykinin, a potent vasoactive peptide. In contrast to vasoconstrictor angiotensin II, endogenous vasodilator bradykinin is typically destroyed by ACE. Thus, when ACE inhibition happens, bradykinin levels increase and angiotensin II levels decrease. This causes the blood vessels to expand, blood pressure to decrease, and total peripheral resistance to decrease, all of which reduce the effort required to pump blood throughout the body. This class of drugs includes captopril, enalapril, lisinopril, perindopril, carindopril, quinapril, and ramipril. Angiotensin receptor blockers, ARBs, a different class of related medications, also act on the same angiotensin pathway. This class of drugs includes losartan, telmisartan, irbesartan, candesartan, olmesartan. However, ARBs function by attaching to AT1 receptors found on vascular smooth muscle as well as other tissues, such as the heart, directly preventing the activities of angiotensin II, instead of blocking the enzyme that causes angiotensin II formation. Because of this, the effects are similar to those of ACE inhibitors in that they reduce vasoconstriction and secrete less ADH and aldosterone, which reduces blood pressure and eventually prevents both kidney and heart damage. Furthermore, ARBs are not increasing bradykinin levels since they do not inhibit ACE, because increased bradykinin not only increases vasodilation but also contributes to several of the adverse effects of ACE inhibitors, including cough and angioedema. ARBs are a good substitute for ACE inhibitors in this situation. Many people with heart failure continue to suffer cardiovascular events even after receiving treatment with an ACE inhibitor or an angiotensin receptor blocker. The development of a new class of medications known as angiotensin receptor Neprilysin inhibitors is a result of the increased interest in natriuretic peptides as a therapeutic approach for the management of heart failure. Neprilysin, a circulating enzyme, now limits the positive effects of various natural vasoactive peptides such as AMP, BMP, and CMP by degrading them. Angiotensin receptor Neprilysin inhibitor simply combines angiotensin receptor blocker and Neprilysin inhibitor to simultaneously block angiotensin II receptor as well as inhibit Neprilysin enzyme, thereby preventing it from breaking down natriuretic peptides. This leads to an extension of the half-life of natriuretic peptides and an enhancement to their beneficial actions. Sacubitril valsartan is one medication example from this class. A further limitation of ACE inhibitors and angiotensin receptor blockers, ARBs, is that they are sometimes unable to effectively reduce the overproduction of aldosterone. Therefore, Aldosterone antagonists, a different type of medication, may also be beneficial for some people with moderate to severe heart failure. Examples of medications in this class are spironolactone and eplerenone. Aldosterone antagonists have cardioprotective effects by competitively preventing aldosterone from binding to the mineralocorticoid receptor. This reduces potassium excretion and sodium reabsorption. Because of this, we also commonly refer to this category of medications as potassium-sparing diuretics. Currently, a more potent class of drugs, known as loop diuretics, is needed to relieve volume overload symptoms, even though aldosterone antagonists have been demonstrated to lower blood pressure and have some diuretic action. This class of drugs includes bumetanide, furosemide. Thus, loop diuretics are primarily used to alleviate symptoms associated with lung congestion and peripheral edema. In the thick ascending limb of the loop of Henle, the luminal sodium-potassium chloride cotransporter, which is in charge of 20% to 30% of the filtered sodium, is blocked by loop diuretics to achieve this. So, compared to other diuretic medications, loop diuretics reduce the reabsorption of a much larger quantity of sodium. Removing this sodium and the water that comes with it from the body is helpful in reducing the symptoms of volume overload. As a result, the oxygen demand, cardiac workload, and plasma volume are all significantly decreased. According to what we've discussed previously, loop diuretics can have a number of side effects, including ototoxicity. It can also interfere with uric acid transport at the same site, preventing its secretion and ultimately increasing the risk of gout. Now, in some situations, if a patient is actually intolerant to angiotensin receptor blockers or ACE inhibitors, typically due to severe renal impairment, blood pressure can be managed with a different class of medications known as vasodilators. In this category of medications, heart failure is usually treated with two different medications. First, isosorbide dinitrate causes the vascular smooth muscle cell to release nitric oxide, which in turn triggers the enzyme guanylyl cyclase, which catalyzes the conversion of guanosine triphosphate into cyclic guanosine monophosphate. Reduced intracellular calcium concentrations are the result of a sequence of events caused by elevated intracellular cyclic guanosine monophosphate. And because the contraction is caused by calcium, this reduction eventually causes smooth muscle relaxation and, consequently, vasodilation. Now, in comparison with isosorbide, the second medication, hydralazine, appears to affect the vascular smooth muscle in a variety of ways. These include stimulation of the vascular endothelium's nitric oxide release, which in turn stimulates the production of cyclic guanosine monophosphate and lowers calcium concentration, opening of potassium channels, and inhibition of calcium release from the sarcoplasmic reticulums, all of which help to relax the smooth muscle and cause vasodilation. The most frequent side effects associated with this class of drugs include tachycardia and hypotension. Lastly, before we finish our lecture, I wanted to quickly comment on Digoxin, another medication that can be used to treat heart failure, especially in patients who are intolerant to beta blockers or ACE inhibitors. Digoxin's mode of action is slightly different from that of a vasodilator in that it works by enhancing cell contractility, particularly contractility of cardiac muscle cells. Digoxin achieves this by blocking the heart muscle cells' sodium-potassium ATPase pump, which is in responsibility for bringing potassium ions into the cell and removing sodium ions from it. Because of this inhibition, when the heart cell's sodium concentration increases, a second electrolyte mover called the sodium-calcium exchanger brings in more calcium ions. Consequently, the intracellular calcium levels rise, making the contractile proteins available. As a result, the cardiac output increases and the force of contraction increases. Digoxin has an extremely narrow therapeutic index, and one of the most frequent adverse medication responses that result in hospitalization is digoxin toxicity, digoxin withdrawal, measuring serum potassium levels, and potassium replenishment as necessary are common strategies for managing toxicity. Finally, I just wanted to say thank you for watching. I hope you enjoyed this video, and as always, check back for more. Take care, and good luck with studying.